Okay, my name is Francis Roosevelt Gillum III. I'm Rosie Gillum, and I am a clinical electrophysiologist.
Okay. First question we got to ask, what is that? What is
What is a
electrophysiology?
clinical electrophysiologist?
Yes.
We're a specialty of cardiology. So within medicine, there's internal medicine. Then you're trained to be a cardiologist, and then further training within cardiology specializes you in electrophysiology, which is the study of the electrical disorders of the heart. Patients who have heart rates that are too fast, too slow, or irregular. We deal with those types of patients. People often recognize pacemaker patients or patients with implanted defibrillators, or today we're doing a lot of ablations or catheter-based procedures where we eliminate arrhythmias. That's what electrophysiology does.
Okay. So what causes a heart to either be too slow or too fast?
Well, the main thing is that we really don't know. I mean, it can happen with what seems to be very healthy hearts. Mm-hmm. Some people are born with the abnormality. Some people develop it, and it can, be the result of a damage to the heart. Obviously, certain types of medical problems, for instance, aortic stenosis is very near the conduction system, and very commonly after surgery or valve procedures, they will develop heart block, which means that the electrical portion of the top of the heart is not connected to the bottom of the heart. They may need a pacemaker. Other people will just out of the blue will develop slow heart rates. And then of course they will need pacemakers. A lot of fast heart rates are actually, you're born with the ability to have these fast heart rates. And it may be later in your life before these electrical pathways, or if you will, short circuits, are manifest in a way that you need to do something about them. And those are the patients we may take to ablation.
Okay. So then talking about heart disease and African Americans, what is killing us? What is hurting us the most?
Well, I think it's many things, but specifically in my area of electrophysiology, I tell people, I say the first thing we worry about is keeping people alive. Mm-hmm. And the number one medical problem from an economic standpoint is heart failure in this country. Heart failure, typically we think of hearts that are weak. And we know that people who have heart function measured by their ejection fraction. The ejection fraction is how much blood is ejected from the heart every time it squeezes. Normal being 50%, so we see an ejection fraction of 50% is normal. If their ejection fraction is below 35%, these people have heart failure, yes, systolic heart failure as we refer to it, but they also have a very high rate of dying suddenly, to the point that a person who has heart failure who's admitted to the hospital has almost a 20% chance of dying each year. So that means 1 in 5 people who would have this are at risk. And it's the number one cause of people dying suddenly in this country. It's what we call sudden cardiac arrest. It's an electrical problem that people often think when you hear cardiac arrest, the heart has stopped. Mm-hmm. Well, that's not correct. Typically when you have cardiac arrest, think about it, the TV shows which we so popular see on television, we see people take the paddles and shock people. Well, they're not shocking the heart to start it. They're shocking because the heart is beating very fast and out of control. This is a big problem in heart failure. And as a result, African Americans suffer from cardiomyopathies in which the heart doesn't squeeze very forcefully, have heart failure, and are at very high risk of dying suddenly. So what do we do about it is, as an electrophysiologist, if we cannot correct them by medicines or other interventions to restore normal and strong function to the heart, we implant a device called a defibrillator, which is like a pacemaker, but instead of predominantly working with heart rates that are too slow, we work for heart rates that are very fast and can actually deliver the shocks that can save someone's life. And it's a matter of life and death in this population. So that's one of the things that as an electrophysiologist we do every day.
Okay. So is there anything a patient can do beforehand to stop this sudden cardiac arrest?
Well, obviously the thing that we like to encourage is anything that's good, smart, heart healthy to do first off, because it's a lot better to prevent disease. And so we still know the biggest cause of people having decreased heart function is people who have heart attacks. So we encourage people to do all the smart things. Don't smoke, take care of your blood pressure. If you have diabetes, take care of your diabetes, exercise regularly. And when you notice something about your body that's not just right, see your doctor and evaluate and try to prevent the routine things that you see for heart disease. But if you have a bad heart, let's say you have heart failure, then a big part of this is education. You need to know about sudden cardiac arrest and sudden cardiac death and decreased ejection fraction. We often tell people you should know your EF. You should know what your heart function is if you are a heart patient, because if that EF number is consistently below 35, the next question is, do you have a defibrillator? Because if you have an ejection fraction less than 35, you're at risk. And if it's not going to be fixed, you're going to potentially need to have an implanted defibrillator.
So we have some questions about, can fibromyalgia affect your heart?
Can fibromyalgia affect your heart? Well, fibromyalgia is a connective tissue disease, and a lot of people have connective disorders that will affect the heart in many ways. Does it specifically affect the heart? That's one of those problems that we're still trying to sort out, because I think fibromyalgia and its impact on a person's total health is still being considered at this time. But I think it's safe to say that any concomitant illness, whether it be fibromyalgia or a number of the connective tissue disorders such as systemic lupus erythematosus, all these can be put together with psoriasis, rheumatoid arthritis. All those are connective tissue disorders, but otherwise other diseases, infections, anything that can impact the heart and change how it works certainly can put you at a greater risk of having cardiac dysfunction, which we refer to as a cardiomyopathy, meaning that the muscle doesn't squeeze very forcefully. And all of these things put you at a greater risk of potentially dying suddenly, in which case a defibrillator may be necessary to have.
Can you explain more about left ventricle diastolic dysfunction?
Okay, left ventricular diastolic dysfunction. Now that's different from what I described earlier as systolic dysfunction, in which the heart squeeze is less. Think of diastolic dysfunction as the heart being very stiff and not distensible. And I tell someone, I say, and this is probably not the best way, but it's a nice understanding. When you try to blow up a balloon the very first time, it is very hard to blow that balloon up because the elastic forces of that tries to push it in place. But after you've blown it up several times, the balloon is a lot more pliable. It's easier to blow it up. Well, diastolic dysfunction, the heart goes exactly reverse. It starts off very easy and flexible, so when the heart is filling, it can actually blow up easier, if you will, holding more blood so that when it pumps a certain or greater volume of blood. But if the heart gets thicker, it gets stiffer. It becomes a little bit like that balloon that you've had to blow up. If you only have a certain amount of force, you can only get a certain amount of blood into the heart. So it pumps less, and it does so at a greater pressure. So the heart becomes dysfunctional in a way that, it still looks like it's squeezing very forcefully, because if we measure that ejection fraction, which is the problem in systolic heart function, which is low, but if you look at diastolic dysfunction, it's high. So the heart looks like it's functioning very well, but yet the patient is still having heart failure. They're still having fluid in their lungs. They're not doing well, and it's because the heart is not as pliable, it's not flexible, it's stiffer. So it just doesn't function as well. That's a hard problem right now in cardiology for us to work with, because we don't have a real good fix for this problem. And that's obviously something as a physician, it's very discouraging.
I have a question for you. What are some of the symptoms for heart failure?
Well, heart failure, which is prevalent, can be anything from shortness of breath. If someone says they're used to walking, a mile. All of a sudden they walk 500 feet and they're short of breath because their lungs are full. People with heart failure may also have swelling in their lower legs. We call it edema, means that they are backing up fluid and holding on to fluid. They may gain weight, which leads to being short of breath. They may have trouble when they lie down, particularly, because think about a bottle of water. If it's upright, the water's all at the bottom. If you lay it down, it layers out. So in patients who have heart failure, they're not keeping up fluid out their lungs. When they're standing upright, the fluid may be at the base of their lungs. When they lay down to go to sleep, it layers out and they wake up short of breath. So we get a lot of people sleeping on 2, 3, and 4 pillows, or sleeping actually upright in a chair. All these are symptoms that a person may have. The big symptom they may have is they may pass out. That may be a problem. But typically we look at shortness of breath, decreased energy, swelling in you may notice it in their legs or abdomen, and that's representing the fluid that's backed up from the right side of the heart. But if there's fluid from the right side of the heart, think about the fluid that collects also in your lungs, and that's what gives you the shortness of breath.
So, okay, so what about chest pain? So that doesn't come into play. How does that come into play?
Okay, chest pain, now you're talking about a problem that's related to the number one concern that we as cardiologists publicize, which is coronary artery disease. And we think of occlusions of the arteries that feed blood to your heart. You have 3 major arteries that carry blood to your heart. And when we talk of heart disease and cholesterol and blockages, for the most part, cardiologists are focused on coronary artery disease. So if an artery in your heart becomes partially blocked, it limits the amount of blood that goes to the area of the heart that artery or blood vessel carries to. And that means that blood, which carries oxygen, carries away waste products, and it actually is the if you will, the supply of those heart cells. If limited blood supply gets to them when you are at rest and then you start exercising, less blood gets to those heart cells. Those heart cells are denied oxygen and denied nutrients, and they hurt. And anyone who's like run track or run at all can tell you what we call oxygen debt. When you start running and you start getting pain in your legs because your legs aren't getting enough oxygen. Well, your heart, when it doesn't get oxygen, it hurts you as well. And that chest pain, which we refer to as angina, refers to areas of the heart not getting enough blood. And when that happens, the ultimate progression of that, of course, if you block enough of the blood flow, those heart cells don't get enough blood and they die. And when a heart cell dies, that's what we refer to as a myocardial, meaning heart infarction death. So heart death, myocardial infarction, or layman's term, we say heart attack. So a heart attack basically means part of your heart dies and it can't be recovered. Because once a heart cell dies, it's dead. So you have a certain number of heart cells, and when they die, that's it. So you can't make new heart cells. That's why heart attacks are so critical. So when we see someone with chest pain, that's a warning that part of the heart is not getting blood. So what do we want to do? Then we can intervene by looking, ultimately with cardiac catheterization, to identify which artery or arteries are blocked. And then we can sometimes open them up with balloons or stents. If there are many, many blockages, or if they're in places we can't easily reach, we even have to sometimes take them to bypass surgery. Bypass surgery is just what it sounds like. The blockage may be here in the vessel, and you connect a vessel like a vein or an artery to bypass that blockage to restore blood flow beyond where that blockage is located. And so that's what bypass surgery is, and that's how it relates to chest pain.
So how can you tell the difference between a heart failure, chest pain, and maybe like gas or heartburn?
That's an excellent question. How do we tell the difference between chest pain that's from your heart? or chest pain from stomach or even chest wall. And it's really hard. I mean, it's not a given. I mean, and that's what makes this so difficult. And, you know, we really have to listen to our patients. And this is one of the things that particularly when you go to physicians, that people have to be good at making their doctors listen to them. Because, you know, sure, I could say, oh, that's just, you know, your stomach or just heartburn. But, you know, sometimes it's not heartburn, it is your heart. And there's really no way to be absolutely certain in many instances, and we have to do tests. So the first thing is to have a suspicion that this could be your heart. So, you know, one of the things that we know that African Americans and women have pain that is different from the classic textbook. Oh, I have the squeezing discomfort in my chest when I'm shoveling snow. They may have something that feels like indigestion, or just may have a numbness in their arms, but your suspicion needs to be there that this could be their heart. In which case, then you will do some specific, we call them non-invasive tests. We don't immediately take everybody to do a catheterization, but we may do things like treadmills or nuclear medicine studies, tests that are not invasive or less dangerous, that can give us a clue. So if they have an abnormality in one of these non-invasive tests, we say, okay, there's a problem here. We think it could be your heart, but the gold standard is when we look and see the blockage that would be done at heart catheterization. The goal, of course, is to do this before there's damage to the heart. That's the goal.
So, as far as going back to preventative, is there anything you can eat that will help to, well, I guess it's less preventative, to clear the arteries?
Well, I think that what you do is you start off by looking at all the various risk factors that people have. And I encourage people to say, okay, look at your family. And family history counts. If you have early heart disease in your family, and African Americans, you know, by some of our new criteria, as many as 40% of African Americans will have high blood pressure. So if you have high blood pressure, if you have diabetes, and one of the problems that African American women specifically have is that by the time they're 50, many, even at this point, most African American women are very overweight. And if you look at overweight with high blood pressure creating diabetes, we refer to that as the metabolic syndrome. And those people are at higher risk for heart disease and stroke. So the best preventive measure is to start early on with not just, you know, what you eat. I often tell people, I say, you know, I don't really care what you eat. And I know this sounds so blasphemous as a cardiologist. Okay, but there's a proviso. It depends on how much exercise you're willing to do. So if you look at that donut and that represents an hour on the treadmill, and if you're willing to do that hour on the treadmill for that donut, then, you know, in Johnny Cochran's term, he said, if you're prepared to do the time, then do the crime. But if you're not, don't. So if you look at a blast furnace, it's hot. It'll burn anything put in it. So if you look at your body as that furnace, and you're willing to exercise extremely hard. And if you think about 18-year-olds, they're running around all the time and they're busy, and we really don't worry about what they eat. Matter of fact, we're trying to figure out what it is we can get them to eat, because they don't seem to gain weight, they don't seem to do it, because they're extraordinarily active. Now, if we can adopt that as an adult, as a patient, if we're active, it does two things. And I tell people, I say, you want to control all the medical problems you have, but from your diet and exercise, if you exercise a lot, one of the things you do is you give yourself an early warning system. So if a patient comes to me and says, Doc, I feel bad after walking 2 miles, I'm thinking to myself, I don't know what that means. I mean, is that means that they're walking 2 miles, and that's some patients, that's pretty good that they can walk 2 miles. But if a guy comes to me and says, look, here's my workout record. I've been walking 5 miles every day for 3 years. And now all of a sudden, I get short of breath and don't feel good after walking 2 miles. I'm going to say, we need to find out why. So before he's even had a problem that's severe, it's something he may have noticed because he has records of his exercise, I'm going to start looking. Now, if a person doesn't do anything but go from bed to chair to walking around, the first instance that they may have a problem is when the problem is really bad or they have the big heart attack. So if you stress the system, you find out much earlier time. That's your early warning. I tell my patients, if you let me know what your records are. The other thing we do is we empower patients today to use technology. We have smartphones, we have smart watches. You should have, every African American family absolutely should have a blood pressure cuff in their family. And every person, young, old, and not so old, should take their blood pressure daily, write it on a calendar, month at a time, and take it to your doctors when you go. Go to your doctor with some numbers and be prepared. You're paying money for that visit. Get something out of it. You would not go to your accountant and say, oh, I left my records at home, and pay for that visit. So, I mean, you say, well, no, when you go to your tax guy, you got all your records because you know he's going to charge you. You don't go to your lawyer to buy a house and say, left a check at home. So why do you go to your doctor and say, we want you to extract everything out? Because you only get out of it what you make your doctor do sometimes. And if you come in there with good blood pressure records, then you'll find that maybe I don't need as much blood pressure medicine, because we know that your blood pressure is going to be higher in the doctor's office than it is at home. You don't live in the doctor's office, you live at home. Your blood pressure needs to be controlled at home, not at the doctor's office. So you come prepared. It's like a test. And I tell my patients, I give them calendars. And I say, okay, this is your homework. Come to me with your homework. So don't make me be an English teacher and say, your composition at home on your desk. Say, oh, what do you think your English teacher going to do? They going to give you an A because you left your composition? You say it was a great one. I don't care how good you say, tell your English teacher that you did a great job on that composition. You don't have it, it doesn't exist. You bring your records into me, I look at them and I look at these numbers and I say, guess what? We get to take away some of your medicines. Another thing I tell patients regularly, go to the doctor and say, these are the medicines you're giving me. Can I stop any of them? One of the things everyone's really talking about, this opiate epidemic we have in this country. But we also have an epidemic of too much medicine because people see many, many doctors now. 40 years ago, maybe you saw one doctor, but the patients that I see often will have 3 or 4 other doctors. And I often say, think about this as a smart test. I think I'm a smart guy. I'm that way of thinking. But if I had to remember to take 10 medicines every day, I'm sorry, I'm not that smart. So I don't figure that my patients have to be that smart either. So I look and say, well, what medicines am I giving this person that may have expired their time? Maybe they don't need them anymore. But you know something, if you don't ask, you know, maybe it doesn't get addressed. Simply put, the squeaky wheel will get oil. And if you don't squeak a little bit when you go see your doctor, you ask the worst doctor visit I can imagine. A patient comes in, I say, how you doing? He said, fine. Okay, see you in 6 months. You haven't gotten anything out of that. The doctor certainly hadn't done you any good. I mean, so you need to go in there and say, well, you know, no, you're taking care of my blood pressure. There are my blood pressure readings. Look at them. You know, do I need to take these medicines? Now, the doctor may say, yes, you need them. There's certain medical problems. We talked about heart failure. There's a lot of medicines people need in heart failure. So, but any medicine you can get rid of saves you money and lessens the chance that you're going to have a medicine that interacts with another medicine that you might need in a negative way. Yeah. So those are some basic things I tell people from a preventive standpoint. You can do better if you come prepared. Think about the things that you need to do for your health. How active are you? A lot of this isn't rocket science. I tell my patients too, why do you smoke? It makes no sense to smoke. Anyone born after 1960, not only does it make no sense to smoke, I almost say and say, are you just, you know, just crazy? Are you dumb? You know, because it says on the side, that's poison. It's going to kill you. not maybe. There's no question. Now, our grandparents and parents who were born in the 30s and the 40s, they knew no better, and they knew that this was something that was cool, and they did not know how addictive it was. Anyone born after the 60s have no excuse. So if you are smoking then, it means you have a death wish. So I'll jokingly tell patients, but in all seriousness, I say, look, you're paying me to make you well, and you're buying cigarettes to kill you.
Right.
I say, pick your poison. Do one or the other. Either get on living or get with dying. But don't waste your money. And I say that in hopes, obviously, for my patients to stop smoking, because that's one of the things you can do. Wear seatbelts, stop smoking, take care of your blood pressure, take care of your hypertension, and everybody ought to get exhausted once a day. So if you want to do some exercise, 30 continuous minutes until you're exhausted. And my grandmother used to have a saying back in South Carolina, so tired you can't go another further. One step more you just can't take. If you do that every day, then a big part of your problems will go away. Because, again, diet is controlled by how much exercise you do. If you exercise enough, that chocolate cake is not a problem. If you exercise enough, that fried chicken is not a problem. But if you don't exercise enough, you can't diet enough if you don't do it. You fill the car with gas, you park it. When I go there a week later, the gas is still there. If you eat, that's your gas. If you don't do anything to get rid of it, it's going to be there.
That is some great information.
That is. So doctor, tell us a little bit about your background. What drove you how did you know you wanted to be a physician?
I actually didn't have an idea about being a physician. I think I was in high school. My brother and I were football players, and my brother was much better than I was, I might add. So as a result, in 10th grade, he was actually playing with the varsity. And he broke his ankle really severely at one of the away games. And I was not playing. I was there. But the long short story of this was that a week later, he went from being potentially never to walk again to having an orthopedic surgeon repair his leg. And 2 years later, as seniors, we were both on the same football team playing together. And, to me, it was a life-changing moment for him, obviously, but also it was a job that I said, well, this sounds good. I'll be a doctor. So I went to college knowing nothing about medicine other than it looked good, and on TV, of course, there's a medical center doctor that looked like a fun job to have. And so I went to med school, and, who knows? I ended up in cardiac electrophysiology, something I'd never heard of, actually, before I even got into med school. So I think that the one thing about medicine is fascinating. It's a great opportunity to do a number of things with it. And I pretty much tell every young person looking at it, I say, it's what you think about medicine going in. It's probable that your thoughts are going to be expanded so great that it will not resemble what you thought you knew going in. There's so much to be done in medicine today, and it's such a wonderful career. You get so close to people, you can do so much good. So I sort of came into it because I saw my brother helped by a doctor, and I thought it'd be kind of a fun thing to do. And I haven't been disappointed.
Wow, that's amazing. Are there any skills or abilities that a young person, if a person is getting a math or a science or something, are there any traits or skills that might signal to a young person that they may be a good physician?
Well, I think the one thing that any person going into medicine should have is care for their fellow man. So I think if you start off with what we've talked about today is patient-centric medicine, meaning that you put the patient first, or that everything you do is around the patient. When it comes to clinical medicine, anyone who has the ability to be caring or empathetic or for their fellow man it almost means that it depends on how determined you are. Certainly, you have to have the ability to do the sciences, because that's a big part of medicine. But if I look at the classmates that I had in med school when I was at Duke, there were people who were English majors, who were history majors. We had people who were actors and actresses off Broadway. We had dancers. We had a whole collection of different people from different walks of life, rich, poor. We had people from cities, from rural areas, and they came together to form the class that was in my med school class. So I walk away today thinking that the skill that people have most importantly is a burning desire to succeed at med school and a willingness to work hard to get good grades, because you need to compete to get into med school. So it's not something that you can wake up today and says, I just want to do it. I mean, it's something that you have to plan, be willing to take the classes that are necessary to in college to qualify for med school. But that being said, people who are good at math, yes. People who are good at science, absolutely. People who are great at English, yes. We need writers in medicine. Do we need sociologists? Absolutely. Do we need people who are humanists? Yes. So I don't think there's any one characteristic of a person other than driven to do something special for their fellow man. Willing to do that, there's a space for you somewhere in medicine.
Where can we find you?
Me?
Yeah.
You mean?
The people in live, like if they want to get in contact with you, or if they want
Twitter,
to look
LinkedIn.
up.
Oh,
Yeah.
I guess I am on LinkedIn. I am on LinkedIn, and I'm at Rosie Gill at Twitter at Rosie Gill 16, and I'm on Facebook. I'm a really terrible Facebook person. I mean, I see it, I'm there, and I'm on Twitter, and I'm on LinkedIn. That's Francis Roosevelt Gillum,
Perfect.
and I'm in Sumter, South Carolina.
Awesome. Well, thank you
Right
so much. We really
Thank you,
enjoyed
guys.
that. You got a lot of engagement. They're really happy and saying it was very informative and thanking you. So thank you again.
Thank you, guys. I really appreciate what you're doing. If there's anything you need me to do, call me.
Yes.
You got my car. I left it with
Okay.
you.
Will do.
And thank you, guys. I'm glad.